Those who are eagle-eyed among you will spot that my title is actually a little bit different from the one that was given to me. And before the organising committee gets too upset, I have actually kept to the brief as is within the title to a certain degree, but I have taken a little bit of liberty, because I suppose if we think about progress to date, I mean, the bottom line actually should be summarised that the progress to date isn't as great as we want it to be. And no amount of navel gazing and reviewing of literature or anything like that really is going to take away from that key point. And I think what the purpose of today is about is actually concretely moving forward, getting actions together that we actually can implement, that we can transform the care that we're providing to patients. So for that reason, I'm actually not going to look too much to the past in terms of progress to date. One cannot argue with the fact that there are, of course, demonstration projects nationally and also internationally, but they do tend to be, certainly in the jurisdiction of Ireland, to be rather more smaller scale projects. And as yet, there really aren't plans for widespread implementation of those demonstration projects. And in terms of plans for the future, well, that's an even a little bit more of a sobering question, because to be honest, there is also a deficit in terms of planning for the future, in terms of meeting the palliative care needs of people with disability. There is reference in policy documents. There, again, there are, moves in terms of demonstration projects and so on. But as an absolute clear timelines, deliverables, that is lacking. And part of the reason, really, why today is so exciting is because it is about getting that energy behind the movement to progress palliative care for people with renal disease and their families. And in some respects, while the answers aren't out there, the answers are in all of our hands. And that's actually a very, I suppose, empowering, enthusiastic, perhaps, impassioning place to be moving forward. So really what I'm going to try and do is perhaps to think a little bit about what might be that best way forward if we don't have an absolutely clear roadmap when we're particularly focusing on palliative care for people with renal disease. So a typical talk really would be, moving from a state of kind of questioning or perplexity or lack of knowledge to this last 5 minutes of the presentation where there's a wonderful conclusion slide and you all get your 4 taken home messages and hallelujah, we've got it all sorted. This talk is going to be a little bit different from that because I don't think we're quite yet at the pinnacle of our journey really in the terms of provision of palliative care for people with renal disease. So really what I'm going to be doing is really considering some of the issues that are facing us, asking some questions, and really asking questions of ye within the audience to think about, to generate the answers, because you are the experts here. You are the people that are providing palliative care for people with renal disease, and therefore it is collectively that we need to come up with these answers. And then I will perhaps suggest some next steps and perhaps give you a little bit of idea of what plans there are out there in terms of moving things forward. Now, I am conscious, as I've mentioned, that we are from different geographical areas and we're also from different disciplinary areas. So we do need to perhaps just do a little bit of a sense check to make sure that we're all on the same page and talking about the same things. And there are some things that we do definitely, every one of us share and have in common, which is a good thing. So I think in terms of terminology, everybody really would understand and subscribe to the definition of palliative care as is the WHO definition of care. So really just emphasising that holistic approach to care provision for people at any point in the trajectory of their illness, from point of diagnosis to end of life, and indeed extending into bereavement care for people, for the families of those who are left behind. So I think that is very much a commonality that we have. When we're talking about palliative care, everybody does understand that as being what we're talking about. Interestingly, there is a little bit of a difference when we use the term end-of-life care between the North and the South. So in terms of the North, end-of-life care is generally meant to that holistic care approach, but perhaps within the time frame of the last year of life. And we've already had reference to the surprise question as perhaps being a trigger or an indicator to focus on that period of time. Whereas in the South, we do tend to use the term end-of-life care, focusing more often on the actively dying phase, the last days, weeks of life, as opposed to looking at it at that time block of a year of care. I'll come back to that and some of its implications in terms of planning in the future. Another thing I think we do all share in common is a belief that palliative care provision is actually the responsibility of every health and social care professional working in the health system. Okay, so it's not something that resides within the remit of specialist palliative care providers. It is something that should be a core part of every health and social care professional's working responsibilities, in the same way that infection control is a core part of everybody's responsibilities, child protection, so on and so forth. But we really need to move palliative care to the mainstream, that everybody recognises that it's part of what they do. However, we do recognise that staff will possess different levels of competency in terms of palliative care provision. And certainly in the South, we look at the fact that perhaps we describe people as having kind of 3 levels of competency, ranging from the palliative care approach, which are those basic communication and pain and symptom management skills, understanding of a trajectory of illness, and perhaps a need to consider advanced care planning, and a need to respond to, say, carer support needs. So that palliative care approach is ideally embedded in everybody's education and training skills at an undergraduate level, but because unfortunately we have to do a bit of catch up there, a lot of this palliative care approach is actually getting embedded in at CPD level. But ideally, in a perfect world, in 5 or 10 years' time, everybody coming out from training will have that palliative care approach competency. Then we have the level 2, which is the generalist palliative care level of competency, which are those people who, while their day-to-day job isn't palliative care provision, they do actually come quite frequently in contact with people with serious or life-limiting conditions, and therefore they do require an extra level of upskilling or training that they may take at certificate, diploma, or indeed even master's level. So an example for that, I suppose, in the cardiology services might be the consultant cardiologist who's a heart failure specialist will be very much practicing, or should be practicing, at a generalist palliative care level, whereas perhaps the interventional cardiologist who's down in the cath lab may be okay getting away with a palliative care approach level of competency. Interestingly, I think renal is an area where perhaps one could argue that more people are edging towards the generalist level of proficiency rather than necessarily the palliative care approach level of proficiency, or at least key people within departments should have that generalist level of competency, and everybody should be very comfortable with the palliative care approach level. So that's perhaps something for you to think about in terms of operationalising into the future. So those are our 3 levels that we tend to use in the South. More broadly, you can just group them into level 1 and 2 being generalist palliative care providers, and level 3 then being specialist palliative care providers. And then specialist palliative care providers are those people whose core responsibility, their sole job really, is in the care of people with serious or life-limiting conditions, and they have recognised training or experiential pathways to enable them to work in that role. So the levels can be applied to staff in terms of their competency, and to a certain degree they can also be applied to services. So if you were talking about a service that, say public health nursing, that could be operating as a level 1 or a level 2 service depending on the skill mix within that particular region or area. And ideally, again, moving into the future, one would be suggesting perhaps we should be looking in a planned manner to be standardising this, because we're all familiar with perhaps areas where the generalist palliative care providers are particularly good, and then areas where perhaps there is a little bit more of a deficit in the services. So again, we need to move towards standardising that and not having such a kind of a postcode lottery. Final, just a few principles in terms of making sure we're on the same page. I think, again, we would all agree that palliative care should be provided on the basis of needs. Okay, so that is, it's not dependent on age or diagnosis or location or place of care. If a patient has a palliative care need, then there should be a service to meet those needs. Now, interestingly, again, this is where perhaps a north and south thing comes in a little bit, because I would potentially argue that if you're really operationalising palliative care as being end-of-life care in the last year of life predominantly, you're actually tying it to a time period. Now, you could say that, yes, we'll provide for care outside of those periods, but if you're mainly relying on the surprise question as a trigger to activate consideration of palliative care needs, then potentially people outside of that trigger will not receive palliative care. Now, this is why all the policy and strategy documents are always, have all the riders attached to them. The surprise question shouldn't be used as the sole method of assessing palliative care need, and you use other things like the GSF triggers and and clinical judgment and so on and so forth. But I think we do need to recognise when we're setting up systems across countries, there can be a tendency that people will opt to do the simplest or easiest part, you know, and that's the bit that we just need to have a continuous kind of a safeguard checking, making sure that we have the safety elements within a system to make sure that people don't go for too simplistic an approach to assessment of need. It can be argued that people then with serious or life-limiting illness can be grouped into 3 levels of need: those with predominantly lower intermediate complexity needs, those with intermittent complex needs, and those with ongoing or continuous complex palliative care needs. And you get the idea that obviously here we start looking at the idea of matching your level of service to your level of need. So that predominantly people in the first group would be cared for by generalist palliative care practitioners with perhaps the support of specialist practitioners. The ones in the middle would have an intermittent involvement with specialist palliative care, and the ones in the final group would have a continuous engagement with specialist palliative care services. Now again, cautioning against oversimplistic approaches to this. The bottom line is that I've never yet met a person that easily fits into a category. Okay? So what you have to remember really with life-limiting illness is that it's hugely dynamic, and systems need to be sufficiently flexible to respond to those needs, okay? So we really need to, while categories are useful in terms of helping people understand the broad parameters of how things might be organised, you really need to make sure that we don't view these kind of levels as being hierarchical, simplistic or one-dimensional. Basically, generalist and specialist palliative care services, or levels 1, 2 and 3, should be seen as the same side of the coin, okay? One can't exist without the other. Generalist palliative care needs the support of specialist palliative care, but specialist palliative care would absolutely fail without generalist palliative care. So it's not an either or option, it really is the both. So in terms of, models of palliative care provision, if we were to ask the question, what is the best way forward? Well, somebody who was coming up with a health policy or a strategy would be thinking in their head, what is the model of care that we should be looking towards describing? And basically a model of care is this idea of an overarching design. Okay, so there actually is planning. It's not meant to be back of an envelope. An overarching design for the provision of a particular type of healthcare service that's actually shaped by a theoretical basis, that it has evidence-based practice, and it has defined standards attached to it. It consists of defined core elements and principles and has a framework that provides the structure for implementation and the subsequent evaluation of care. So the model of palliative care provision in Ireland is actually based on the National Advisory Committee report of 2001. And also then we have a children's palliative care strategy that provides the model of care for us that was published in 2010. And the Living Matters, Dying Matters document really provides for the model of care in Northern Ireland. Now, the interesting thing about the National Advisory Committee report is that it does a really, really good job of describing the model of care for specialist palliative care provision. And actually internationally that would be recognised, and in a systematic review of models of care, the Irish model is recognised as being a very detailed model with regards to specialist palliative care provision. So for those of you who aren't familiar, it's all about the idea of the specialist palliative care units as being the hub of the services, comprehensive daycare, outpatients, community, hospital-based services, and the levels of care provision, the staffing, the skills, all of those things, the standards attached to them. The National Advisory Committee report also does a good job in describing the interface between specialist and generalist palliative care and recognising the importance of the two pieces working together. Now, the report was only really meant to have about a 5 to 7 year lifespan. And the initial focus of the document was on specialist palliative care in terms of initially developing services. And the expectation was that people would move on to generalist palliative care and describing that model of care at the time. But that hasn't happened. And actually where our National Advisory Committee document is weak, and this is really in retrospect, an unfair judgment considering it really wasn't supposed to do that. But where there is less description is what is generalist palliative care provision and what is the model of that. So living matters, dying matters, and I suppose from the UK's point of view, the end-of-life care strategy actually did do a better job at describing that model of generalist palliative care provision. And if you look towards the UK, obviously the three pillars of that generalist palliative care provision would be the Liverpool Care Pathway, the Gold Standards Framework, and the Preferred Priorities of Care. And those were the model elements that they said would help support generalist palliative care provision. So I'm going to come back to that a little bit, because I think really generalist palliative care provision is the point where arguably all policy documents fall short. Because I suppose if you were to look at the success of implementation around some of the elements of generalist palliative care provision, there might be some questions as to perhaps were some of the right decisions made for some of those elements. And that's important to us, because if we're thinking about palliative care in non-malignant disease, the key message that keeps coming up time and time and time again is that when you're moving into chronic disease, it's the generalist palliative care practitioners that absolutely have to be the absolute focus of your service. To a certain degree, when you're looking at cancer, the oncologists focus on the chemotherapy. They can do pain and symptom management, but the trajectory of illness lends itself to an easier integration of services. People tend to stop chemotherapy in the months prior to death, so there can be not always, but there can be a slightly clearer delineation between interventional and a sole focus on palliation. Even those chemotherapies that people tend to get towards the end of life aren't those ones that say they're often outpatient chemotherapies, oral-based chemotherapies, ones that have a better quality of life and less symptom burden associated with it. Whereas if you look at chronic disease management, what do you see, say, with heart failure? You see inotropes use, you see LVADs, you see ICDs, you see all of these things that are very technological and interventional, that require the ongoing involvement of generalists. And actually, to be honest, we haven't any drug any palliative drug that does a better job than, an inotrope. If you look towards renal disease, what are you looking towards as well? You're looking towards intensive fluid management, you're looking towards inotropes, you're looking towards technologies around dialysis and so on. So there is a challenge within the integration and palliative care within chronic disease management that really means that the part of our strategies that we're perhaps the weakest at, which is generous palliative care provision, are actually the bits that are going to be critically important moving into this arena. So just thinking about palliative care in renal disease, clearly everybody's sold as to why we should be talking about this topic. We're all here today. But just as a reminder, there is evidence of considerable need, and this will be covered in more detail in subsequent speakers' talks. But Fliss Murtagh, when she was doing one of the revised population-based needs assessments in 2014, estimated that in high-income countries, between 69 to 82% of those who die need palliative care. Now, that could be either specialist palliative care or generalist palliative care. We haven't yet the methodology to break down who fits into which camp, but it just shows there is the need. And based on that, Pauline Kane, one of the a research fellow attached to King's, and Fliss and Barb Davison, myself and Regina would have done a similar analysis, like slightly more limited by the data sets in Ireland, which has been submitted. But in Ireland, what we're looking at in the south is 559 deaths of patients with palliative care needs with renal disease. So not a huge number, on the positive side. This is a doable task, but just to give us an idea that there are patients who have needs. So of that proportion, who should get specialist palliative care, who should get generalist palliative care? We don't know. David Currow's work in terms of the strategy document in Palliative Care Australia would suggest, on the basis of the information that they had at that time, that patients with non-malignant disease, about 50% should get referred to specialist palliative care for assessment, about 30% will need ongoing care, and about 10% will have ongoing direct, continuous involvement in care. You could argue really to what degree these figures are absolutely rigorously based. And certainly if you look towards the cancer figures, at the moment, specialist palliative care in Ireland is certainly providing higher proportions of care that would have been estimated in this document. So there is a need, and we're saying why palliative care in renal disease? Well, because we're saying that palliative care has a role in meeting those needs. And it's just something I think that we need to just take a little bit of a step back as a sobering step when we're thinking about moving forward. How good is the evidence that palliative care actually appropriately meets the needs of people with life-limiting conditions? So what is the evidence of effectiveness? And these are just 4 kind of systematic reviews that have been carried over the time, and I'm conscious that in 2014 there have already been 2 hugely important papers published around the value of palliative care, one in the BMJ recently around hospitalisation, and one, Peter Hudson I think is one of the American journals, either JAM or Annals of Internal Medicine, around community palliative care provision and definitively showing benefits of that. But if you look at the early studies, Zimmerman would have said there were 22 randomised control trials of palliative care versus something else, and actually in 10 of the studies that looked at satisfaction, 7 showed benefit. In the 13 that looked at quality of life, only 4 showed benefit. In the 14 that looked at symptoms, only 1 showed benefit. You move up Higginson, you get a slightly better performance as time is going by. And in Johari's study, looking at 22 randomised controlled trials that were either on specialist palliative care or treatment with a palliative care intent, satisfaction is again high at 7 out of 10, quality of life improvement 5 out of 7. And then there would have been a cost effectiveness study published by Aoife Smith and Charles Normand in TCD this year that would have shown that palliative care generally is evident to show evidence of cost effectiveness. Now, that's a little bit of a sobering thought, because I don't think anybody coming in here today would necessarily have kind of thought that I'd be saying palliative care might not be helpful. But that actually isn't what I'm saying. There are 2 key things. The first is that actually all of these studies have, all of the earlier studies are absolutely methodologically flawed. And you can see all the reasons down in terms of the limitations of the studies. So a failure to find a value for palliative care in the early studies actually, to a large degree, could as much have been about the methodology of the study as it actually was about the finding. And you'll see as people have been learning along the way, the studies have got more sophisticated, the methodologies have gotten better, and we've now started to be able to actually tease out the benefits attributed to palliative care. But it does ask a little bit of a question. In some of those studies, a failure to show benefit could have been really due to the fact that the wrong model of care was actually being studied, or even the wrong elements within the model of care. Okay, so that's just that little bit of a sobering thought as we're kind of moving forward now in terms of what do we want to do into the future. We do have a responsibility that we need to do things properly, or at least if we don't know exactly what we're doing, that we build in evaluation to what it is that we're doing. So that we can actually, I suppose, evaluate what it is we're going forward. And that's why that bit about models of care, and at the end it said building in evaluation of those models of care, because there has been obviously that hugely sobering factor. The dangers of the wrong model of care or the wrong element of care is, of course, the Liverpool Care Pathway. And that's not to knock the Liverpool Care Pathway in any shape or form. The Liverpool Care Pathway was, a very well-motivated idea that, to move away from the hype and everything in the newspapers, when used well, does help care. But the problem was that a problem of implementation. You move from a small-scale study where you have a lot of people that are motivated, that are buying in, that are familiar with the service, and then you jump from that into the big wide world where literally, we're all at the receiving end of it in terms of health services. An email comes down on Monday and says, by the way, this is the pathway that has to be in operation by close of day. And you're kind of going, what? That's the gap. Okay, so really when you're thinking about models of care, you have to build in all those variables so that you actually have to make sure that the model works in the worst of situations as well as in the best. Okay, so it's a bit like airlines, you don't want to get on a flight that kind of gets there in good weather, but in bad weather is a little bit more of a debatable option. So we need to build in robust models of care for people with renal disease, because the worst thing is that if something doesn't go according to plan, then really it takes away from the brand value of palliative care, which is hugely important in terms of conveying the value of the message of palliative care to patients, families and other practitioners who be referring to services. So I've really kind of said what is the model of palliative care for patients with renal disease. I don't have an absolute answer. I'd be very interested in all of your thoughts and opinions and comments from the ground. As you'll be aware, Flismerta in King's College London is obviously doing a lot of work in the area, and there's certainly people very much exercising their minds around what this model of care might be. But I think even in the absence of having an absolutely definitive model of care, I think, there are key elements that we can say with reasonable certainty should form part of our model of care, and it is a starting place for us moving forward. And those key elements really relate to, if you want to think about the philosophy of palliative care, and then Donna Beaton's structure, process and outcomes. But again, that caveat, it's important to recognise that any model of best practice in palliative care provision must be, by definition, be flexible enough to adapt to various social and cultural settings, and it must meet the specific needs of the patients and their families. And this is really because there isn't any single or easy definition of what constitutes quality of life for people with serious or life-limiting conditions. And there isn't any absolute definition as to what constitutes a common death. There are a lot of areas of commonality, there are a lot of areas of agreement, but there is always somebody who will have a slightly different take on what those best elements are. And really the heart of palliative care is that individualisation of practice. So I would suggest that the elements, the starting points of a model of palliative care provision, in terms of the philosophy, it actually should be firmly tied to the holistic definitional approach of palliative care. And the reason that I would say that is, and I know this is again something that is a personal opinion and that there will be differences in the audience, but I suppose if we were to look at our experience in the South, where it has been tried to be using end-of-life care as the last year of life, that's probably best seen in the residential nursing home setting, where HIQA, our Health Information Quality Authority, who regulates that area, has used the term end-of-life care. So the Standard 16 is end-of-life care, and that did derive from the Departments of Health use of that term in the legislation. But if you look at HIQA's 13 features of what a service is meeting Standard 16 or meeting good end-of-life care provision in the nursing homes, 8 of those standards are actually, eight of those features are actually related to care of the dying, the actively dying patient, or care of the bereaved or bereaved individual's family, or last offices and orders. Hugely important parts of care, but 8 out of the 13. So the remaining 5, 2 of them deal with palliative care, and 3 of them you could actually argue whether or not it is really looking towards end-of-life care in terms of care towards the last weeks or months of life rather than earlier. So I just think in the way that we're all used to the idea that in palliative care you continually have to, I suppose, walk that balance between a medicalised model that maybe might overemphasise pain and symptom management at the expense of a holistic approach to care, I think you do need to, look a little bit about a reductionist approach to palliative care, that people will very much get on the bandwagon of pain and symptom management, especially in renal disease, and a lot of the papers are around about all of that, and neglect some of the other holistic, attributes of care, which patients and their families say to us are hugely important. So again, it's not that, of course, when those terms are used properly, that problem doesn't arise, but it's just, being clear about what we're saying and what it is we're doing. Argument about palliative care being provided on the basis of needs, I would say that should be upfront. And I'm going to talk a little bit about that you should have levels of 3 ascending specialisation, that levels for us in Ireland services should be organised around the palliative care report. So even though predominantly it's been oncologically based in the early days, that model is appropriate for non-malignant care also. Very clearly in terms of the processes, we need to build into any model of care that the provision of palliative care is the responsibility of the whole healthcare system, and that the process of care needs to be integrated. And that bit about flexibility, that we need to build in a model where you have flexibility, that people can move between the different levels of service, and that recognising that in such a complex model there's a danger of disintegration and fragmentation, you need to build in care coordination into that model of care. So to a certain degree you'll say, yeah, but that's all rhetoric, they're all principles, none of them can actually disagree with it. When you actually come now as a nurse manager, how do I integrate palliative care into the practice of all of my healthcare team members? How do I go about doing that? Well, some of the ways of operationalising those elements are indeed within the Living Matters, Dying Matters strategy, and some of them are within the National Advisory Committee report, and some of them are the remit of, I suppose, my role as the clinical lead of the palliative care programme. And so some of the ways that we've gone around trying to operationalise these elements, translating these aspirational ideals into real concrete actions that will make a difference to patients, is the first is actually having a national eligibility and discharge criteria. So that's to be launched in September. It has been agreed, but in essence what that says is that all services in Ireland will actually provide palliative care on the basis, all specialist palliative care services in Ireland will provide specialist palliative care on the basis of need, not diagnosis. We give an example of what kinds of complex needs we predominantly look towards, but we give a statement to say that ultimately if a patient is referred to the service, if there are any grey areas, then the patient should be assessed and a determination of how best to meet those needs to be made at that point in time. But really what it does is a clear statement of fact that there's no postcode lottery. Everybody will be aspiring to providing the same service. Importantly, within that also, we're going to have clarity around what the discharge criteria are. And again, that's that piece around national discharge criteria. The next piece that we've done and we've referred to is the competency framework. So the competency framework has actually been completed. Their electronic copies will be available for next week to people start working with them, but the formal launch will be in September. But the competency framework actually tells you exactly what each health and social care worker, whether that be nursing, medicine, care attendant, psychologist, spirit chaplaincy, whatever that be, it tells you exactly what are the skills and attributes at 3 levels of practice. It tells you about what the common knowledge, skills and attributes are for all members of the team, and then it tells you about the discipline specific ones. So again, if you were to look at your team, if you're a manager of a service, then what you start doing is perhaps saying, well, how about building into my workplace assessment how well people are meeting those needs? Or the next time we're thinking about CPD and we're sending somebody on courses, we actually found that we had deficits in these areas. We need to start looking towards that. And we're going to use it in different ways in terms of shaping the development of curricula and so on. I've said that I think palliative care should be provided on the basis of needs. Now, that gives us a little bit of a problem, because if we're saying it's on the basis of a clinical assessment of needs, that means that we need to provide guidance on how people to assess those needs. So again, our needs assessment guidance document, which is a simple 8-page document, which actually is much easier because there's lots of tables in it and everything, so it's very user-friendly with a poster for simple reference. But the needs assessment guidance, again, has been completed, and there's a Train the Trainers programme, which has been completed hopefully by the end, by mid-July. I'll check with Michael, but whether we're actually going to go for a launch over the summer, but we'll hedge our bets and say for September. But the idea is that we're going to have Train the Trainers on needs assessment guidance, and we're actually aiming of a partner of a specialist and a generous palliative care practitioner to then be the trainer in your workplace to go back and be able to train people in needs assessment. So the trainers will have 2 workshops in e-learning, but then the people who are being trained on the ground, the programme is designed that actually can be done as part of regular workplace, so you don't need to take time out or anything like that. And there's backup e-learning modules if people want for reinforcement, but the training should be part of that. My caution around the surprise question, I do think that the surprise question can be useful and that prognostic triggers can be part of needs assessment. But actually, if you look at the 2 papers on on the surprise question in the renal population, the first paper in Moss in 2008, looked at the use of the surprise question in patients with hemodialysis. They actually found that it only had a sensitivity of 45% and a specificity of 80%. And the second paper was on peritoneal dialysis, again with sensitivity and specificity. What does that mean? If a test is sensitive, then what you want it to do is to pick up everybody in that category. So in the first paper, only 45% of times did that actually pick up somebody in the last year of life. And actually the paper comments that more people died in the group, would you be surprised they died in the last year of life? More people died in the group that was, yes, I would be surprised, than in the group that, no, I wouldn't be surprised, although the numbers were small. And then the specificity is, when you get that answer, yes, no, I wouldn't be surprised, therefore they have palliative care needs, are these people actually in the last year of life? And again, you can see the performance in those figures. Why is that important? Well, it means that if you're only relying on the surprise question, you're going to miss a lot of people that have potentially palliative care needs. And the danger of therapeutic nihilism may come in those patients that people think are in the last year of life, and there may be a failure to pursue rescue. Now, again, that's kind of an extreme position, but these things need to just be thought about. In terms of training, we also have pain and constipation guidelines that will be launched in September. So really, again, with users' guides, manuals and training to try and help generalist practitioners understand and know what are appropriate guidelines. And then we've got quality assessment and improvement guidelines and a rapid discharge pathway, which I can talk about a little bit later in questions perhaps. So I suppose those are our efforts to operationalise these things that I think are specifically and directly of relevance to the renal population. So my conclusions really is that unarguably there is a need for palliative care provision for people with renal disease and their families. However, the best way, I think, people would have to concede, isn't absolutely known as yet. However, it's really important to recognise that many elements of the existing model of palliative care provision are indeed appropriate and should as a first step be built on. So there shouldn't be any paralysis at this point in time. We've plenty of things that we can and should be doing moving forward. We just need to think about some of the aspects of generalist-specialist interface. We need to work out better ways of doing that, and we really need to focus on that. Some of the elements that do need that greater clarity and to promote implementation are around the generalist palliative care practice, and the ways that typically people would approach such a problem are developing tools, guidelines, pathways, educational methods to promote patient awareness and involvement, which is something we don't talk about very much but hugely important. So in order to answer exactly those questions, local innovation really needs to be encouraged, but I really would urge everybody that there should be a robust evaluation of effectiveness before we move towards nationally implementing it. And so further details about this can be found in the palliative care programme. And just as a final word, I'd just like to thank everybody who has contributed and worked with the palliative care programme, and particularly our strategic partners such as the All Ireland Institute, the Irish Hospice Foundation, the Irish Association of Palliative Care, without whom documents such as the competency framework or the needs assessment guidance could not have been completed. Thank you.